Ritesh. Good evening, everyone. I am your host today, and I have a fantastic crew. It's a fantastic journey as well. My crew members are, you have seen the moderators and organizers. So we have vibrant team of Dr. Ritesh. Along with me, I have Dr. Azam. So all three of us will be helping you as well as we will move on with this wonderful journey. Uh, I'm taking this privilege to introduce you to all that clavicular block is one of the block very near and dear to everyone. So, Hetal, Ritesh, your screen is locked. You can unlock it. I mean, it's okay. So, starting with our first speaker. Yeah. Starting with our first speaker, I'll just. Yep. So it is always pleasure to introduce Hetal Vadera. Hetal Vadera is a very warm of uh, of ISA. Just a minute, I'm just sharing the screen. Yep. Yeah. So Hetal. So about Hetal, Hetal is a fantastic regional anesthetist. He also does neuroanesthesia as well as bariatric anesthesia. Extremely warm gentleman. As I have been to Rajkot, I have seen his team. Extremely hardworking and always ready for help. He has publications in various international journals, and he has brought Rajkot to a very different level. When we talk of India as a whole, Rajkot definitely has a place in regional anesthesia, and it is definitely the lion's share is because of Dr. Hetal Vadera. So we are starting with Hetal's presentation on infraclavicular block. So I'll be just be sharing. Are you able to see this presentation?
Yeah. Can you see the
screen? Yep. Continue.
Is it visible?
Is it visible?
Yes, yes, Hetal.
A very good evening to all of you. Myself, Dr. Hetalkumar Vadera. I am a consultant anesthesiologist at Sterling Hospital, Rajkot. First of all, I will like to thank Academy of Regional Anesthesia, India, for giving me this opportunity to speak to all of you. I am going to talk about PNS guided infraclavicular block. This is a very important block. In the era of ultrasound guided blocks, PNS guided blocks looks like it is an inferior block or it is not that effective. But in India and in many countries, ultrasound is not available to all. Especially for freelancers, ultrasound is a distant dream. So PNS will be important. A PNS technique will remain always important for freelancers and institutes where ultrasound is not available in operation theaters. So I am going to talk about PNS guided infraclavicular block. So if I talk briefly about anatomy, all of us know this. This is brachial plexus. If you look here, these are the roots, these are the trunks. Here are the division, and if you go down, there will be cords and then distal nerves like median, ulnar, radial, or musculocutaneous nerves or other nerves. So if you look, if you give a block at the level of trunks or at the level of roots, it becomes your interscalene block. It is used for shoulder surgeries. If you go further down, just above the clavicle, lateral to the subclavian artery, you will find divisions of the brachial plexus, and if you block at this level, it becomes your supraclavicular block. And this is important for surgeries of whole upper limb, and it is like a spinal of upper limb. So you can do any surgery with or I will say most of the surgery with supraclavicular block. If you go further down at the level of chords below clavicle, if you give the block, it becomes your infraclavicular block. There are different variants of infraclavicular block, and you can do it at different levels. If you look at this anatomy image, this is basically of ultrasound guided costoclavicular approach of infraclavicular, where axillary artery, this is axillary artery, this is axillary vein, and these are the three cords lying lateral to the artery just below the clavicle. So at this level, VIB falls at the same level. So if you inject the drug at this level with single injection, you can block all three cords, and you can have an excellent effect with low volume of the drug. If you go further laterally, just below the coracoid process, cords will take their anatomical positions, like lateral cord will remain lateral to the artery, posterior cord is posterior to the artery, and medial cord is medial to the artery between artery and vein. But it is not fixed. There are many anatomical variations. Sometimes posterior cord lies posterolaterally, medial cord lies posteromedially, lateral cord is at supralaterally, and sometimes at but lateral cord is always most and then it suddenly disappeared from the practice. It was not even in the textbook of regional anesthesia. In 1973, Dr. Prithviraj, who is the I will say Bhishma Pitama of regional anesthesia, introduced it again into practice. He was going at the midpoint of clavicle. He was directing the needle toward axilla and stimulating the cords with the needle and giving the block. Then came the Whiffler's approach. It was basically giving larger volume, just like Pericoracoid approach, and he was giving it without PNS. But most popular technique are pericoracoid infraclavicular block and vertical infraclavicular block. So why we need infraclavicular block? We have supraclavicular block. If we want surgery in distal part, we have axillary block. With that, there are less chances of, if you compare it with a supraclavicular block, infraclavicular is with less chances of pneumothorax. There are less chances of phrenic nerve palsy. In fact, with pericoracoid approach, there are less chances, almost up to zero, of phrenic nerve palsy. With VIB, there are 25% chances of phrenic nerve palsy with higher volume. And it is a best approach for catheter placement, because it is a muscular area and catheter get fixed easily, and there is no movement in this area, so catheter remains there at the place, and you can give continuous block. If you compare with axillary block, in axillary block you require abduction, which is not required here. If you want to prevent tourniquet pain, it is difficult with axillary block. But if you give infraclavicular block, it is just like a supraclavicular block. It gives similar effect. Musculocutaneous now is not spared with infraclavicular block most of the time, which is paired with axillary block, and you cannot place a catheter in axillary area. and the posterior cord and medial cord. Then came the Whiffler's approach. It was basically giving larger volume, just like Pericoracoid approach, and he was giving it without PNS. But most popular technique are Pericoracoid infraclavicular block and vertical infraclavicular block. So why we need infraclavicular block? We have supraclavicular block. If we want surgery in distal part, we have axillary block. With that, there are less chances of, if you compare it with a supraclavicular block, infraclavicular is with less chances of pneumothorax. There are less chances of phrenic nerve palsy. In fact, with Pericoracoid approach, there are less chances, almost up to zero, of phrenic nerve palsy. With VIB, there are 25% chances of phrenic nerve palsy with higher volume. And it is a best approach for catheter placement because it is a muscular area and the catheter get fixed easily, and there is no movement in this area, so catheter remains there at the place, and you can give continuous block. If you compare with axillary block, in axillary block you require abduction, which is not required here. If you want to prevent tourniquet pain, it is difficult with axillary block, but if you give infraclavicular block, it is just like a supraclavicular block. It gives similar effect. Musculocutaneous nerve is not spared with infraclavicular block most of the time, which is spared with axillary block, and you cannot place a catheter in axillary area. So if we talk about VIB and pericoracoid block, this is the clavicle, this is the axillary artery, this is the axillary vein, and these are the three cords. So at the VIB level, or just below the clavicle, all three cords lie lateral to the artery. So superficial most is the lateral cord, then you find the posterior cord, and medial cord is the deeper most. But if you go a little distance away, if you go little laterally, then they will take their anatomical positions, like medial cord will go between the artery and vein, posterior cord will be posterior to the artery. So at the pericoracoid level, you will find these cords lying lateral to the artery. So if we talk about VIB, that is vertical infraclavicular block, anatomical landmark is first is jugular fossa or suprasternal notch. You have to palpate the suprasternal notch. Then you palpate the ventral apophysis of acromion. Draw a line joining it. Then go just inferior to the clavicle and insert the needle perpendicular to the skin. At this level, plexus lies superficial, so you require 5 centimeter needle. Usually you will find the plexus from 3 to 5 centimeters, so you don't require longer needles here. But there is an issue. There are difficulty in landmark identification. So how will you identify the landmark? Especially ventral epiphysis of clavicle is difficult to palpate. Jugular fossa is easy to identify, but sometimes you will palpate the coracoid process, or sometimes lateralmost part of the acromial process, or sometimes humeral head. So there is difficulty in identification landmark. So what will you do? You need a simple tactic. You have to go from behind. First palpate the spine of the scapula, go from midline, go laterally, palpate the lateralmost part of the acromion, and then go for ventral part of the acromion process. So palpate from medial to lateral, go anteriorly, and then palpate the ventral apophysis of acromial process. So this is how you can locate from behind. But there was an ultrasonographic study by Greher et al., who suggested a modified method for VIB. He showed that with 20 centimeter, if the distance between suprasternal notch and ventral apophysis of acromion is 20 centimeter, then it is an optimal length. If it is 22 centimeter, you can insert the needle at 11 centimeter and you will find the plexus. But if patient is shorter, length is less than 22 centimeter, then you require some modification. Then you have to move 0.2 centimeter laterally for each 1 centimeter below 22 centimeter. So suppose if it is 20 centimeter, you have to go 0.4 centimeter lateral to the midpoint. So mark a point at 10 centimeter, go 0.4 centimeter lateral to it, and you insert the needle. Otherwise, there are chances of pleural puncture, there are chances of vascular puncture. And if patient's height is longer length than 23 centimeter, then you have to move medially. 0.2 centimeter medial for each 1 centimeter above. But in Indian subcontinent, usually patients have length less than 22 centimeter. So correction for smaller patient, as I said, shift entry point to 0.2 centimeter laterally for each centimeter of clavicle that measures less than 22 centimeter. So suppose if it is 18 centimeter, then 22 minus 18, that is 4 centimeter, multiplied by 0.2, that is 0.8 centimeter. So entry point should be shifted 0.8 centimeter lateral from the midpoint. So this is small correction for smaller patient, and if you do it, you will find the plexus easily. Second most important point, needle direction should be never medially. If you go medially, you will puncture the vessel. If you go medially, you will puncture the pleura, and chances of complication is higher. So never direct the needle medially. Always go perpendicular to the skin. If you don't find the response, go caudally or go cranially and look for the response. If you still don't find the response, look for the landmarks, again mark the landmarks, and if required, go more laterally rather than going medially. So here you can see I am doing the mistake. Here I am going medially. This is the lateral, this is the medial, and here you can see I am directing the needle medially. This should not be done. Otherwise, there are chances of complication. So never direct the needle medially. It is a wrong technique. When you insert the needle, initially, what happens initially? You will find a response of pectoral muscle contraction. That is basically because of contraction of pectoral muscle, because of stimulation of lateral and medial pectoral nerve. So if you find that response, you don't need to inject the drug there. You need to go deeper to find the proper plexus. So this is fine. You find the pectoral muscle response, ignore it, go deeper, and you will find the response. Initially, you will find the lateral cord response, that is the flexion of the first 3 fingers and opposition of the thumb. If you find this, you can inject the drug there, but chances of failure is high. So you have to go deeper, and you have to find the posterior cord response, that is the extension of the fingers. So you insert the needle and look for the extension response. If you find the extension response, then you can go for it. Here you can see I set the PNS at 1.1 milliamp. Don't go for 1.5 milliamp because it will cause a great jerks in the hand, which is painful for fracture patients. So if you find this response at 1.1 milliamp, reduce the current to 0.5. If a response is still there, you can inject the drug there. You require 20 ml of 0.5% bupivacaine or ropivacaine for surgical anesthesia. If you want to use for analgesia, then 0.2% ropivacaine or 0.25% bupivacaine is enough. So at 0.5 milliampere, if you find the response, inject the drug. But you reduce to 0.3. If you still find the response, then don't inject the drug. Readjust the needle and then only inject the drug. Here, this is very interesting. This was the patient where I give VIB and scan in the supraclavicular area. Here you can see this is the subclavian artery. This is probably pleura. This is the first strip, and this is the plexus. And here you can see the drug is spreading proximally as well in the proximal area, that is supraclavicular area. So you can see the drug here. I scanned further upward. These are the scalene muscle. This is the interscalene area, and still you can find some drug there. So we will see that there are chances of 25% chances of phrenic nerve palsy with VIB if you inject higher volume. So this is how drug spread proximally in the plexus, and sometimes it causes phrenic nerve palsy. Second approach is pericoracoid approach. It is lateral approach, so less chances of phrenic nerve palsy, less chances of pneumothorax, but it is bit deeper. Here plexus go deeper, so you have to use larger needles, longer needles to find the plexus. Landmarks are simple. You have to palpate the coracoid process. If you cannot find the coracoid process, you put your fingers medial to the humeral head. Ask the patient to abduct and adduct the arm. Bone moving underneath your needle, underneath your finger is the coracoid process. So that is how you can palpate the coracoid process. Mark a point 2 centimeter medial and 2 centimeter inferior to it, and that is your entry point. So success rate is low with single nerve stimulation, better to perform multiple nerve injection, but when you inject the drug surrounding posterior cord, sometimes you don't get response for lateral cord and medial cord because drug is spreaded around lateral and medial cord as well. So sometimes it becomes difficult, but if you can stimulate all three cord, success rate is higher in literature. So here you can see I have marked the coracoid process. This is the clavicle, 0.2 centimeter medial and 2 centimeter inferior to it. I am inserting the needle and looking for the response. Here you can see this is the patient of AV fistula. I am inserting the needle perpendicular to the skin. I am going inside. I will like to see posterior cord response, but if I cannot find the posterior cord response, I can inject the drug with lateral cord or medial cord response also, but success rate is low. You can see I'm locating the plexus. I can see some contraction. I'm checking which response it is. You can see the flexion of the fingers, and that is probably because of the stimulation of the lateral cord. I am reducing the current, and here I am injecting the drug. So with that you can also inject the drug, but it is better to go for posterior cord response. This is the musculocutaneous nerve response. If you find this, never inject the drug. This is because of flexion at the level of elbow. Musculocutaneous nerve gets separated sometimes at the level of pericoracoid approach, and if you inject with this, your entire plexus will be spared and there won't be any effect. So with this response, never inject the drug. This is the most desirable response, that is the posterior cord response. So if you get the extension of the finger, then you can inject the drug and you will have an excellent effect of the block. You require 30 ml of 0.5% ropivacaine for surgical anesthesia or bupivacaine for surgical anesthesia, and 0.2% or ropivacaine or 0.25% bupivacaine for analgesia only. You can put a catheter here with a posterior cord response, and you can continue 4 to 6 ml per hour 0.2% ropivacaine for surgical anesthesia, especially for surgeries of elbow or forearm. So if you compare VIB with pericoracoid, VIB is superficial, it is less painful. Pericoracoid, it is a deeper approach, it is more painful as you pass through the muscles, so you require some good local infiltration. VIB is single injection. For pericoracoid, it is recommended multiple injection. VIB you require 20 ml of LA, while with pericoracoid you require 30 to 35 ml of LA. With VIB, but with VIB there are higher chances of pneumothorax and phrenic nerve palsy, while with pericoracoid there are less chances of pneumothorax and phrenic nerve palsy, but it can happen if you are going for multiple injection. There are chances of pneumothorax with pericoracoid approach also. With VIB, less chances of vascular puncture because you are doing single puncture, but with pericoracoid there are higher chances because you are looking for multiple responses. VIB, as I said, require less volume, 20 ml is enough. For pericoracoid you require 30 to 35 ml of LA. Possible complication, as I said, with supra pneumothorax is 0.5 to 6%, but with VIB and pericoracoid it is 0.2 to 0.7%, so it is less as compared to supra. And phrenic nerve palsy with supra it is 50%, with vertical infraclavicular or VIB it is 25%, and with pericoracoid approach it is almost 0%. So complication rate is lower compared to supraclavicular block. Failure rate with if you can stimulate the posterior cord, failure rate is low, 5.8%, but with medial cord and lateral cord, failure rate is higher. So this is all about VIB and pericoracoid block. These are the simple blocks. You can do it with PNS, and you can have excellent analgesia with less chances of phrenic nerve palsy and pneumothorax. Some of the beautiful innovation is are prepared by Dr. Maulik Mehta. He is a very good friend of mine, and he is practicing at Ahmedabad. He is a regional anesthesia enthusiastic. So I'm thankful to him for providing this this beautiful animation. Thank you, all of you, for your attention. Thank you very much.
Thank you, Hetal. I think that was really a very elaborate presentation on the topic. Now, without wasting much of time, we have our second speaker, Dr. TVS Gopal. As we all know, he is chairman of Aora. He is he is mentor of many regional enthusiasts. He is past president. Under his belt, Aora has progressed to international levels. May it be starting of ADRA Center in India. You all know that when it comes to demonstration of blocks, live demonstration, it was always, uh, Dr. TVS Gopal and his famous infraclavicular block. So today we are very fortunate that the topic like infraclavicular block is given to him. His voice is magical. It has a bass. So it will not be an overstatement if we call him like Amitabh Bachchan of AORA. And we are so happy that he inspires all of us. Thank you so much for being here. Over to you, Gopal sir.
Sir, you're on mute, sir. Okay. Thank you for your flattering words of introduction, Amit. That was fantastic. Being compared to somebody as vocal as Mr. Bachchan himself, that is an insult to the big man. Hetal spoke very well about PNS-guided infraclavicular brachial plexus block, and in the next 30 minutes or so, I'll be talking about the ultrasound-guided approach to the infraclavicular brachial plexus. I've been asked to plug this into my, just doing that. Okay. Okay. So when we do the infraclavicular approach to the brachial plexus, we are targeting that area which is highlighted in that red rectangle. So this is the place where the elements of the brachial plexus have reorganized themselves to form three cords, as Hetal told you: the lateral cord, the posterior cord, and the medial cord, all so called because of their spatial orientation to the axillary artery. The ultrasound guided approach to this particular block was actually not very old. It was discovered in 2000 by Utaki and colleagues from Japan. What they did was quite interesting. They didn't actually look for the elements of the brachial plexus, which is the cords in the vicinity of the axillary artery. They directed the needle 15 millimeters medial to and 15 millimeters lateral to the subclavian artery, and then they proceeded to perform the deposition of local anesthetic. So as you can see here, this is the axillary artery, and you have a spread of local anesthetic all around the artery, and that's how the ultrasound-guided infraclavicular brachial plexus block began. And thereafter, it is now Prakash Sandhu, who works in San Diego in the United States, who made ultrasound guided infraclavicular brachial plexus block very much his own because he did so much work on this. He had several publications on this block. And he was one of those anesthetists who was responsible for making this a very popular block in our armamentarium when we practice regional anesthesia. So if you look at this particular picture, you will see that the muscles over here of the anterior chest wall have been removed. And this is the infraclavicular fossa. And this is divided into a medial infraclavicular fossa and a lateral infraclavicular fossa. So to begin with, we will concentrate on the lateral infraclavicular fossa. So when you concentrate on the lateral infraclavicular fossa, that becomes a lateral sagittal approach to the infraclavicular brachial plexus. So this placement of the probe just distal to the clavicle and medial to the coracoid process is called the parasagittal plane. Now, when you do this particular block, you will be targeting the elements of the brachial plexus at the level of the cords. And these cords are deep to the pectoralis major and pectoralis minor, and obviously the clavipectoral fascia that encases the pectoralis minor and the subclavius muscles. You must please remember that the subclavian artery becomes the axillary artery at the lateral edge of the first strip. So here, you're actually targeting the cords in the vicinity of the axillary artery and not the subclavian artery. The posterior cord obviously lies posterior to the axillary artery. The medial cord is caudal and the lateral cord is cephalad. But that said, there are tremendous variations. So if you see this particular slide, you see the artery. In fact, even when it comes to the position of the vein, there are so many variations. Not so many variations with regard to the lateral cord, but several variations when it comes to the placement of the posterior and medial cords. So when you perform this block, you tend to abduct the arm on the side of block away from the body. By doing this, you're dragging the plexus away from the pleura, so the chances of injuring the pleura when performing this block is minimized. You reduce the depth from the skin to the cords, and you also create a space for needle insertion here, because if you see, the clavicle angulates superiorly as you move laterally when the arm is abducted. So when you talk of ergonomics, the operator will be standing at the head end of the patient. This is where we position the ultrasound machine, and the non-dominant hand will be holding the probe, and with the dominant hand, we introduce the needle. You can use any of these transducers for this particular block. My personal preference is to use a high frequency linear transducer. Some tend to use a curved transducer because, especially in big patients, obese patients, these cords in this particular the lateral sagittal approach, they lie fairly deep, and some people like to use a curved probe. Whereas this is a microconvex probe, which Dr. Sandhu uses for all his blocks, no matter which part of the body he performs them in. So I hold the probe with my non-dominant hand. This is the parasagittal plane, and the needle goes in plane with the ultrasound beam. So this is in plane with the ultrasound beam. So if you look at this particular picture from a volunteer, that's the skin, this is the subcut tissue, this is the pectoralis major, this is the plane between the major and the minor, this is the pectoralis minor, this is the axillary artery, and that is the axillary vein. This here is definitely the medial cord. This definitely is the lateral cord. But where is the posterior cord? It could be this, but this could also be a posterior acoustic enhancement artifact. Or I would think that this is the posterior cord in this particular patient. This is another volunteer. This is the axillary artery. This is the vein. This is definitely the posterior cord here. This is the lateral cord. Now, where is the medial cord? I really don't know. There is a hypoechoic shadow here, which is likely to be a tiny branch arising from the axillary artery. And so this is probably not the medial cord. So I put these pictures to you to show you that picking up all three cords in one window is not always easy. There are two approaches to performing the lateral sagittal approach to the infraclavicular brachial plexus. One is a single injection technique, and the other one is the triple injection technique, where you target all the three cords individually. When you do the single injection technique, you will want to bring your needle here and deposit your local anesthetic so that there is a U-shaped spread of local anesthetic, which will affect the lateral cord, the posterior cord, and the medial cord. This is a short video. You see the needle coming in there. So the target would be to place this needle just posterior to the axillary artery. And as we make our injection, you should be able to see the U-shaped spread of the local anesthetic. So that's the local anesthetic coming in there, and that is the U-shaped spread. Now that is the posterior cord, that's the lateral cord, and that would be the medial cord over there. So this is how you do a single injection technique. This is a block which I performed at GARC in 2015. It has a voiceover, so I'm just going to play the video and keep quiet till this is over. That is the baritone voice.
So there is no voice as such. You can.
Artery. So that is a demonstration of how you do a triple injection technique. And the infraclavicular space is actually a very good space to place your catheter, because the catheter will go through the pectoralis major and minor and lie here. So it is secured by the muscles. So this is a short video. This is the needle here, which you can't actually see too well. This is the artery. And as the catheter is advanced past the needle tip, you can see it coming up here. See that? And that's the catheter that is emerging from the tip of the needle there. I'm wiggling the catheter, so you can see this movement caused by the wiggle. And when I inject the local anesthetic, you will see that spread coming exactly here, posterior to the artery, which is the ideal placement for an infraclavicular brachial plexus catheter. It was in 2007 in a letter to the editor of Anesthesia when Peter Hubbard and Royce spoke about the posterior approach to the brachial plexus. But nothing really happened for the next 8 years. It was in 2015 October when Charbonneau and colleagues from Montreal in Canada renamed this block as the ultrasound-guided retroclavicular block. So this is the placement of the needle when you do a lateral sagittal approach. But when you do a retroclavicular approach, the needle is actually placed superior to the clavicle and it will go under the clavicle as it ventures towards the elements of the brachial plexus in the vicinity of the axillary artery. So you've heard about raptors from the Jurassic Park, and now you have a RAPTIR, which is a RAPTIR block. And it is an acronym which stands for retroclavicular approach to the infraclavicular region. So this is how you would put your needle when you do a conventional approach. And with the RAPTIR, this is the needle that goes absolutely flat under the clavicle, and it goes close to the elements of the brachial plexus. So this is the needle path when you do the RAPTIR block, and this is the conventional approach. Here you can see that the angulation of the needle is steep, whereas here it's fairly flat. And in this picture, you can see the tip of the needle is positioned just between the axillary artery and the posterior cord, which I believe is somewhere here. Now, there are advantages and disadvantages of this particular approach. The biggest advantages is you can do this block with the arm lying right next to the patient. This is very useful in patients who've got painful pathologies in that arm that needs to be blocked, and adducting the arm will be difficult. The second most important advantage of this is because the needle is going fairly flat, you should be able to pick up the needle and you should be able to see it quite well. And you can also technically avoid injury to both the cephalic vein and the lateral pectoral nerve, which lie in the plane between the pectoralis major and minor. There are certain disadvantages, and this includes that the clavicle, as we know, being bone, it casts an acoustic shadow. So when the needle is actually posterior to the clavicle, it is not picked up on the ultrasound image. And when a novice is performing this block, if the needle is not exactly oriented with the ultrasound beam, it's quite likely that your needle has advanced quite a bit before you actually pick up the needle. So that way you can cause damage. The second disadvantage is that the contour of the clavicle is not uniform in all subjects. Sometimes there is a steep angulation of the clavicle, and in these people, doing this block is quite difficult. The third and most important disadvantage with this particular approach is that the suprascapular nerve and vein, they lie in the path when you do this particular block. So you can't technically impale the suprascapular nerve. So it is advised that you combine ultrasound with PMS, and if at any time during the performance of this block, there is external rotation of the shoulder joint, that means you're very close to the suprascapular nerve. So you need to reorient your needle to avoid injury to the suprascapular nerve. And the last disadvantage is that cadaveric studies with this particular approach have shown that in 3 out of 6 cadavers, the tip of the needle was in the posterior cord and not in the vicinity of the posterior cord. So to sum up, there are certain problems with the traditional infraclavicular block. One, the cords are located at a greater depth. Two, they are separated from one another. That definitely means that you need to inject relatively large volumes of local anesthetic so that you can have a successful block. As I told you, there is significant variation in position, and you can rarely visualize all the three cords in a single ultrasound window. In 2016, these authors published their landmark article, which was the anatomic basis for brachial plexus block at the costoclavicular space. Now, if you look at this same picture again, we will focus on the medial infraclavicular fossa. If you go just distal to the clavicle, this is exactly where you will have the costoclavicular space. The costoclavicular space communicates superiorly with the supraclavicular fossa and inferiorly with the rest of the medial infraclavicular fossa. So it's not a contained space. It communicates both upwards and below. This has implications, as I will talk about it later. So the costoclavicular space, as I told you, is this space here, which lies, this is anterior and this is posterior. So anteriorly will be the clavicular head of pectoralis major, followed by the subclavius muscle, and posteriorly is the serratus anterior and the intercostals. So medial most is the axillary vein, lateral to the axillary vein is the axillary artery, and lateral to the axillary artery is the costoclavicular space, in which you have all the three cords lying very close to each other. So this is a very compact space. So technically speaking, if you can inject your local anesthetic in the center of this space, you will have a very rapid onset of block, and your block will definitely not have any sparing. So that is the premise between having a costoclavicular brachial plexus block. So if this is a sagittal section going through the midpoint of the clavicle. Now this here is the costoclavicular space, and this is the axillary artery. You will see that the lateral cord lies anterior to the axillary artery. The medial cord lies immediately posterior to the lateral cord. The posterior cord lies anterior to both the lateral and medial cords. And all the three cords lie anterior to the axillary artery. So that is the orientation you need to keep in mind when you approach the cords in this particular space. So if you see this anatomical dissection in a cadaver, this is the axillary artery, medial is the axillary vein, this is the thoracoacromial artery that is taking off. I'll talk about this later. This here is the lateral cord. You don't see the medial cord because it lies posterior to the lateral cord, and anteriorly this is the posterior cord. So as you can see in this particular image here, all the three cords lie anterior to the artery. Now in 2017, the same set of authors expanded on their initial publication by talking of sonoanatomy, technique, and block dynamics. So in this particular picture, this is the patient who is to be blocked. The arm on the side of the block is abducted. The operator stands at the head end of the patient. He is holding the probe with the non-dominant hand. This is where the ultrasound machine is placed ergonomically. And if you see this inset picture, this probe, the high frequency linear probe, lies just distal to the clavicle, corresponding with the midpoint, and lies medial to the coracoid process. So that is how you would place the patient, the operator, and the probe. And that is the placement of the arm on the side of the block. And there is a description made by the authors, which is a sequence of placement of the probe so that you can correctly identify all the structures starting from the clavicle going down to the lateral infraclavicular fossa over here. Now, the medial infraclavicular fossa is bordered superiorly by the angle of the first rib and inferiorly by the pectoralis minor. And the lateral infraclavicular fossa lies immediately posterior to the pectoralis minor. So you start by putting the probe over the clavicle. No prizes for guessing. This is the clavicle and this is the acoustic shadow. And if you move the probe slightly distally, you are actually insonating over the costoclavicular space. So that would be the skin and subcut tissue. This is the clavicular head of the pectoralis major. This is the subclavius muscle. This is the axillary vein. This is the axillary artery. This is the second rib, which lies immediately posterior to the axillary artery. This hypoechoic muscle, this is the serratus anterior. And this here is the costoclavicular space, which contains the elements of the brachial plexus. If you move a little more distally, you will see the cephalic vein crossing over the axillary artery to join with the axillary vein. And if you go a bit more distally, you should be able to see the thoracoacromial artery that is taking off from the axillary artery. And this is the distal most point wherein you are over the lateral infraclavicular fossa. So you have the lateral cord, you have the posterior cord and the medial cord, which is a typical arrangement of the cords around the brachial plexus in the lateral infraclavicular fossa. So this is a recap of the scanning sequence. And this is a short video. So this is the costoclavicular space. You see the cephalic vein crossover. This is the thoracoacromial artery that's taking off. And you can see that it will enter the plane between the pec major and the pec minor over there. That it has entered the plane now. And here you see the typical arrangement of the cords around the brachial plexus in the lateral infraclavicular fossa. So the original description was that the needle should go in plane from lateral to medial. But there are operators who put the needle from medial to lateral in plane. And there are also operators who prefer to perform this block by using an out of plane approach. So there is really no recommendation which way your needle should go. Though the original description of the block was that it should go in plane from lateral to medial. So that is where you would want your tip of the needle so that it is in the center of the costoclavicular space. And the reason for this is quite obvious. You would not want the tip of the needle to be within any of these three cords, and a central placement would ensure equitable distribution of the local anesthetic within the costoclavicular space. So here you see the needle advancing. It is in the belly of the subclavius. Here it is just beginning to enter the costoclavicular space. That's the lateral cord. That's the medial cord. This is the posterior cord. This anatomy is constant. There is no variation as far as placement of the cords is concerned within this particular space. And here you can see that the local anesthetic has been injected. So you can see the lateral cord there, you see the medial cord there, and the posterior cord there. And oftentimes it is always easy to pick up the cords after the local anesthetic has been injected. This is a picture from the nice Aora, just a repetition of what I said. The lateral cord, the medial cord, and the posterior cord, and the needle lies right here, plonk in the center of the CCS. So this is a video here. This was amongst the first few costoclavicular blocks that I did. I could not pick up my needle. But after the injection is made, you will be able to see all the three cords very well. That's the local anesthetic that's being injected there. And in a while, you should be able to see that's the lateral cord, that's the medial cord, and that's the posterior cord. All three cords look quite easy to pick up once the injection of the local anesthetic is made. Now, this is another block which I did a couple of months ago. And here you can actually pick up the needle coming in plane from lateral to medial. This is the lateral cord, this is the medial cord, this is the tip of the needle here, and that's where I begin to make my injection. To summarize, the advantages of doing a costoclavicular brachial plexus block are that the cords of the brachial plexus are relatively superficial in this region. So it is a very useful block to perform in obese patients. They're all clustered lateral to the axillary artery. There is a consistent anatomical relationship. That is the most important point. There is no anatomical variation here. And oftentimes, with a single transverse scan, you will be able to pick up all the three cords. And the conclusion by this particular study was that there is a rapid onset of both sensory and motor block. The readiness for surgery is there within 10 minutes. The motor block of median nerve is slightly slower when compared to that of ulnar, radial, and musculocutaneous. I'll explain that in a subsequent slide. These authors used just 20 mils of 0.5% ropivacaine, and they had excellent surgical anesthesia. The onset was within 10 minutes, and there were no short-term or long-term neurological complications. And if you see this histological section here, this is the lateral cord, this is the medial cord, and this is the posterior cord. Now, the posterior and medial cords have a sheath which goes around them, whereas the lateral cord seems to be separate. Since the median nerve takes its origin from both the lateral cord as well as the medial cord, it probably takes some time for the anesthetist to go past this particular sheath and affect the lateral cord, which explains why the median nerve blockade onset is slightly delayed. Now, this was an RCT which compared both the approaches, and these authors found that there was really no difference whether you did a lateral sagittal block or whether you did a costoclavicular block. Now, in this particular RCT, which was done by Karmakar and colleagues, they showed that there was data in favor of the costoclavicular approach. Now, it is said that the costoclavicular space is the place to put your catheter. This was a topic which actually Sandeep and Amit gave to me to speak at the Prague, which actually stood cancelled thanks to COVID. And we really don't know what happens to the tip of the catheter. Is it going to go up into the supraclavicular fossa, or is it going to travel down into the medial infraclavicular fossa? That is something we will know only when we have injected quite a few catheters. I mean, we put quite a few catheters in clinical patients, and maybe from a series of studies on cadavers. Now, this was a recent study stating the obvious that the costoclavicular block is a very good alternative for obese patients. And this was a very interesting study coming from Siva's department in Ponde. Now, what these authors did is they injected 3 mils of local anesthetic into the supraclavicular brachial plexus. And they saw that after they injected the 3 mils into the supraclavicular brachial plexus, that local anesthetic tracked into the costoclavicular space, and it became easier to pick up all the 3 elements of the brachial plexus in the costoclavicular space. So they call this the pre-injection technique. I have not tried this. I will try this, and maybe once we have the question and answer session, we can have some comments from Siva on this. So my 30 minutes is up, and over to you, Amit, and over to Vrushali. Thank you.
Thank you very much, sir. You have to stop your sharing. Yeah, thank you. Thank you indeed. Thank you very much. It was a excellent description, and there are many questions for you as well. I would like to encourage our delegates. They can put questions to specific speakers in the chat box window. We'll be having a question answer session later. So now we have another speaker, and this speaker will not require any introduction. Dr. Vrushali Ponde, and she will be speaking on infraclavicular blocks, tips and tricks in pediatric patients. So Dr. Vrushali, as we all know, Vrushali Ponde madam, as we all know, is first female president of Aora. She's a director of children's anesthesia services. She is also a program head and the faculty lead for various fellowship programs like WFSA, uh, Aora fellowship, and other fellowships as well. She has written a wonderful book which is very good for all regional enthusiasts, ultrasound guided regional anesthesia in adults and children. Right now the book is in its third edition. She has represented India and shared Indian perspective at different national and international platforms. She was one of the top rated docs in India today in 2018 and 19. She is also a wonderful sitar player. Um, so as we all know, with her cheerful look and all the time, very vibrant as well as encouraging president. So now we'll be starting with her presentation.
I'm extremely enthused and delighted to be here. On a certain day, a young gentleman set out to work. He had a rough day, in fact, but then was trying to mend, and he had a lot of difficulties. He was in a predicament when a young Samaritan actually came and helped him out. And he was sorted. So this is how education opens the doors. We help each other here by sharing whatever we know, learn, and teach. Academy of Regional Anesthesia actually reaches out to every part of this country. But now that we cannot personally be with y'all, we are virtually with y'all. And here, this is how we essentially learn from each other. My topic today is infraclavicular brachial plexus block in children. I don't think there is any more indicated block in children when it comes to upper extremity, because most of the work that happens in children is forearm, hands, and wrist. Shoulders don't happen that often. Humerus, if at all, it's a fracture. Or what I'm trying to tell you is, in nutshell, it is the forearm, the wrist, and the hand that is more worked upon, unlike the shoulder in small children. Well, this block can be given by two modalities, the peripheral nerve stimulation and infraclavicular. The third modality, which is a landmark, which is based on clicks and gifts, just doesn't work here. Maybe axillary somewhere you can think of doing that way in children, maybe. But in this particular block, there is absolutely no role for only landmark guided by the clicks and the gives and the feels of the anesthesiologist. It doesn't. Secondly, this is one block that actually combines the advantages of the axillary and the supraclavicular as such. So it is one of really a very beautifully placed block. Third point in this particular block is the anatomy as such, which is flat here in the infraclavicular area, renders itself extremely well for catheters and catheter fixations in small babies and children when they're extremely wriggly. The axillary catheter and the subclavian perivascular catheter is going to come off very easily, unlike an infraclavicular well-tunneled catheter. Having said this, let's look into the details of the two modalities, because being an anesthesiologist, yes, you are going to handle children, even if you are an occasional pediatric anesthesiologist. This is how the brachial plexus looks in an infant. It is a very compactly placed, superficial, waiting to soak in the local anesthetic, but at the same time, you need a very delicate dexterity to handle this age group. So infraclavicular, let's come to the PNS modality as such. We will take an example of a radial club hand here. When it comes to PNS modality, let us first spend some time into understanding what exactly are the landmarks. We anchor the entire block around the coracoid process. We do not go medially at all. So it is the coracoid process approach. It is a lateral, vertical approach of giving infraclavicular brachial plexus block in children. How do you actually go about palpating the coracoid process is pretty unmistakable, whether it is a 95 kilogram adolescent or whether it is a 9 kilogram infant or even 3 kilogram neonate for that matter. Yes, you do have indications there. The anchor is the coracoid process. How do you palpate it is form the thumb with the thumb, slide the thumb from the clavicle to the humerus. The first bony point that you feel is the coracoid process. You can do it while you listen to me. You will be able to palpate your own coracoid process. Once you have palpated the coracoid process, either put one finger of your left hand on it so that you don't lose it, or mark it so it's there for you as a landmark all the time. Once you have palpated the coracoid process, the needle goes straight vertical with a current of say 1 or 1.5 milliamperes. Once you go through it, you will start getting the twitches of pectoralis major, pectoralis minor, the same logic as adults here, and then you will see the responses akin to what I am showing you in this video. If it's an anomaly, you will just see some flicker going on in the forearm, and you can accept it, and you can give the drug here with repeated aliquots and after, of course, thorough aspiration. If in a normal hand, this is how it is going to look. You will see the flexions of the fingers, you will see the extensions of the fingers, you will see forearm movements, you will see all the story that cord stimulation shows you. Having said this, let us go ahead to what you accept and what you reject. Again, it's similar in adults: finger flexion, wrist flexion, forearm twitches, pronation and supination, pronation and wrist adduction you accept. You do not accept flexion of forearm, which is musculocutaneous, and you do not accept flexion at the shoulder, which is local twitch of pectorals. Coming to ultrasound, let's see what this particular modality actually opens to us. Actually, it opens to us a doorway to place catheters, and doorway to be very, very sure about this block, doorway to really stay away from the one dreaded complication, which is pneumothorax in this particular age group as such. Now, where do you keep the probe, and which probe do you use? You can use a hockey stick probe. Admittedly, you can also use a linear probe. So linear probe is really good enough. It is going to show you all that you need to see. Unlike a hockey stick probe, it's not mandatory. So let's, this is how it is placed, the way it is shown in the picture, and it reveals this sonoanatomy to you. Again, very similar to what you see in adults. Pectoralis major, pectoralis minor, the neurovascular bundle. Anecdotally, this is the lateral, the posterior, and the medial cord, but look how close the pleura is. Hence, the importance of having ultrasound in this age group. Now, the real-time work is something like this. Your needle actually comes towards the lateral cord. See how well it is seen. And I have already injected a little bit of local, and hence it was floating so well. The local is here, you can see it. I may go to the 6 o'clock position, which is the posterior cord. Whether you really make that fuss of going to each and every cord is a question that we are going to answer by the end of this lecture. So the needle is really going to moving towards the posterior cord. Then we may go to the medial cord, which is right here. You can see that. And again, aspirate, inject the drug in aliquots. The local anesthetic that you can use here is 0.2% ropivacaine in a dose of 0.5 ml per kilogram, or you can use have a look at the adult picture here. The depth is huge, and you really need to anchor your block perhaps around the posterior cord for understandable reasons. We go to the dual modality. Dual modality again is an issue here because you can see the needle where it goes, but you may not always see the twitches in an anomalous hand. So I'm not a big fan of dual modality, at least in children. This made us answer a hypothesis as to which modality really worked well in children. And obviously, it was the ultrasound, which we could prove with a good RCT, with a well-cited RCT, in fact. Now, continuous infraclavicular blocks in children. Let's see how we can use this modality to a maximum. This is how the probe would be kept, and this is how the needle goes in. It all remains the same. Now you just pick up the epidural needle, which could be 19 in very small children or even 18 in bigger kids. All that you do is you be at the lateral cord or you be at the posterior cord. You cause a hydrodissection due to some part of the drug that you want to use. Suppose if you have calculated the drug to be of 3 ml of 0.2% ropivacaine, then you put around say 1 ml here, create a space for yourself, put in the catheter, withdraw the needle by inserting the catheter even further. That becomes a pre-tunneling. So approximately 2 to 3 centimeters of the catheter remains beyond the Tuhi needle, and the rest is actually pre-tunneling. You can again tunnel it a little medial as well and get the catheter fixed very well. So finally, the catheter can be fixed the way it is shown here. Put in infusions. It is going to improve microvasculature, and these are the points where you're not going to actually get an end motor response at all. This is the case done by one of our team members, Dr. Dilip in Jupiter Hospital, and this is the case done by me in one of the nursing homes, in fact, where the radial artery was by mistake punctured, and this is how we can get the circulation back. So it's a boon. All pediatric anesthesiologists will come across this kind of a situation, so we should be able to understand the role that a regional anesthesia can play in this particular situation. So this is how we can actually change the whole game. We can make the watershed line recede, and we can salvage hands. But then the calculations really need to be understood of local anesthetic, which we are soon going to look into. So coming to some certain audacious indications, in fact, this was a child who had a lot of coagulation disorders, diabetic in the PICU, was almost losing his fingers, and then we could again, with a continuous block, salvage them. Having continuous block in the postoperative period is again a boon, but you need to understand one thing, that your surgeons would want to see the movement of the fingers. So if you can give them a block which will make them see the finger movements, then it would be good. If you have given a single shot block, do not activate the infusion at least for 3 to 4 hours, or activate to be very safe after they have seen the first movement. And then use ropivacaine because it gives you a good sensory motor separation. And if they get this kind of a block, in fact, they will be able to pick up a compartment syndrome, because if at one given time, at one given strength of infusion, if the child is comfortable eating, talking, and breathing very well, in fact, but then if he is actually grumpy, refuses to eat, gets very cranky and irritable, don't step up the infusion. Ask your surgeons to look into the plaster. Now, what is this big fuss about lateral and medial and posterior cord? Yes, In adults, the literature is overflowing that the posterior cord, being the most central one, is actually the block to go near and give the local anesthetic as such. It really doesn't matter in children. We have convinced ourselves pretty well with even dye studies that whether you are at the posterior cord, whether you are at the lateral cord, you're going to get the same density and the same effective block as such. Coming to the newest kid on the block, which is the costoclavicular as such. So they all are in one nutshell here. So all that you do is come at the lateral most point and inject in children at least. But then does it really matter here now? You can be in any approach. Brachial plexus sheaths in children are very, very thinner as compared to adults, permitting easy diffusibility. So even if you are at the lateral most corner of the brachial plexus, they are going to get soaked up. You can use a volume of 0.5% of bupivacaine or 0.2% of ropivacaine and let the volume be 0.3 ml per kilogram to 0.5 ml per kilogram. It is enough to give you a good block. So this is a table which really gives you the volume of every drug that can be used for any peripheral block in children. In fact, 0.5 ml per kilogram is on a higher side. If you want to give 2 blocks, then you can use it as 0.25 ml per kilogram for those 2 particular blocks, keeping the concentration the same. Local anesthetic dosages for continuous block is something that we really need to ponder upon, because unless this is understood very well, it is not going to be feasible for you to keep continuous infusions in the postoperative period. So this table in nutshell is going to give you how will you calculate. If you have any further questions about it, I would be more than happy to answer. So the take-home messages. PNS has its limitations. We have seen that. We have accepted that. But at the same time, let me tell you that if you do not have ultrasound, PNS, even if you see a flicker in the forearm or the wrist and you inject the drug at 0.5 milliamperage, then you do get a good block in children because we are blessed here to have very supple tissues. Be aware of what not to do here. Pick up your stimulations well and encourage continuous block if the surgeries are very invasive, because in children, even if they go to the floors, people are going to be very worried to give them more painkillers. So regional anesthesia, if you have mastered well and if you know the infusions and play with the infusions well, this is one of the best modalities to treat pain relief or other pain, because you're going to treat pain without respiratory depressions, without nausea and vomiting, and you are going to not stress much the ward staff if you have a team to look after. If you don't have a team to look after, don't go into continuous blocks. You know, I do not like boxers as such, but I do like this beautiful quote this legend had put across. The service you do for others is the rent you pay for your room here on earth. And yes, we owe a lot of rent. So thank you. Thank you very much for the patient listening. I would be delighted once again to answer any questions that you have. Thanks. And thank you for the opportunity.
Thank you very much, Vrushali madam. And we have 1 or 2 videos which Vrushali madam requested us to share, and she will be commenting on those videos. So I would like to play those videos. So this is her first video from her presentation. And let me see if I can put it. Yeah, madam, you need to explain this video. Yeah, madam, can you hear me?
Yes, I can. Actually, there's nothing much to explain. The
You
video
can see anything, but you can't see the classical twitches of the finger. You understand? So what's happening is there is no. आता कमी कर एकदम कमी. 1.1. Oh. Okay, can you see that? कमी करना रे पटकन. कर अजून कर. हाँ बस. गेले आता. ये है नीडल इधर. मेरा नीडल मूवमेंट भी आ रहा है ना तो काफी है. So now I am actually aspirating and I am trying to inject. around the lateral cord. Yeah. See them that great. Yeah. ठीक है? दिख रहा है?
So that was one video. Then there is another video which Madam share with you. I hope this is the correct video.
Share
Actually, this was me and Amit had decided to play them because the pre-recorded lecture as such did not show the PNS responses very satisfactorily. I hope that these particular videos are getting across to you what we want to show you through the PNS modality as such.
Yeah. Thank you very much, madam. Thank you. So fine. It was excellent session. We had demonstration, all those videos. Now we are moving on to question answer session. What we have divided is we have divided whole question set into three, and we'll be starting with Gopal sir. Yeah. So we will first have Dr. TVS Gopal, then Dr. Hetal, and then followed by Vrushali madam. So we'll start with Gopal sir. So there are many questions. To start with, I would like to ask, could you please tell us some of the practical tips, as when people are talking about single injection stimulation, so what should be the end point of needle so as to have, so that we can consistently achieve that U-shaped spread of drug?
Yes. Amit, when you do a single injection technique, the endeavor would be to place the tip of the needle just posterior to the axillary artery. And we can do a bit of hydrodissection there. And once we see the local anesthetic beginning to take a U-shaped spread, then we can go ahead and inject more. So that the trick would be to have the tip of the needle immediately posterior to the axillary artery.
Okay. So,
but sometimes you do have a lateral cord. So I personally prefer not to do a single injection technique. It may be okay when you do a PNS guided block if you get responses from the posterior cord. That is the place to inject PNS guided block. But when you have an ultrasound machine and when you have the benefit of guidance, it is not only more gratifying to target all the three cords individually, but it also enhances the success of the block.
yeah. Another question is, when we try to look at the end point, the needle end point, so what should be our approach? Are we trying to achieve a donut sign around the neural component, or we just deposit local anesthetic at 6 o'clock position posterior to
Yes,
artery?
I mean, the first endpoint would be to have the tip of the needle immediately posterior to the axillary artery. But then there are certain fascial sheets there. So when you inject, lots of times you don't appreciate the U-shaped spread. You need to be able to appreciate the U-shaped spread. You should see the drug going to the lateral cord, which is almost always visible. The medial cord may not be always visible, but once you have that U-shaped spread, one limb of the U going in between the artery and the vein, the medial cord will definitely show.
Yeah.
If after injection of your drug at a single place, you don't pick up all the three cords, then probably your block is not going to work. There is going to be a bit of spare.
Now, as we are aiming at achieving that U-shaped consistently with the triple injection technique, what is your recommendation to have a successful block for surgical anesthesia? How much volume you recommend? Some of us are still into use of 20 or 30 mils. Some have moved to 15. Some have even gone little lower. But by and large, when it is for surgical anesthesia and when it is for post-operative analgesia, what is your recommendation for dose, drug, and concentration?
In an adult patient, when I inject in a single space, for example, if I do a single injection technique, I seldom do it. But I think I would stick to about 30 mils if I am targeting surgical anesthesia. Because I am taking a chance, believing that this U-shaped spread is going to involve all the three cords. So I would like to have a larger volume so that my surgeon doesn't tell me your block has failed. So my endeavor would be to deposit a bit more local anesthetic than I would when I do a triple injection technique. So I would say 30 mils in an adult patient is what I would aim at.
What concentration? Like which local
My standard for blocks for several years has been 0.375% bupivacaine. I take 20 mils of 0.25, 20 of 0.5 and put both in one bowl. It becomes 0.375. If it's for surgical anesthesia, that's what I always do. But if it's for post-op analgesia, well, that's another matter. I mean, we go with 0.2 Ropi or 0.125 bupivacaine.
Now, most of the time when we have used this ropivacaine, by and large, most of the statistical data shows that the onset time is around 15 to 20 minutes when the block action will happen. But as you were mentioning in the costoclavicular section, the costoclavicular block, everyone tells that it is rapid onset. So sometimes when the block is rapidly acting, is it intraneuronal? Are we dealing with intraneuronal injections? People talk about intrafascicular, extrafascicular, and if it is so, what are its implications?
Intraneuronal is something that you simply cannot rule out with the present resolution that ultrasound machines offer. So Siva has an export, which is the Rolls-Royce of sonocyte machines. And each they did a study wherein they tried to do a pre-injection in the supraclavicular brachial plexus so that they could define the elements of the brachial plexus in the costoclavicular space. So to say that intraneural injection when you not a possibility is wrong. It is likely to happen. But I would take comfort from the fact that one, the patient does not complain of shooting pain when the needle actually impales the nerve or the cord. And the second, the person who is injecting does not give me the feedback that he or she is injecting against a very high resistance. So if either of these two don't happen, I would assume that I am not within the cord.
Regarding choice of block. Now we have variety of blocks and our knowledge of understanding of sonoanatomy is also increasing. So what people were thinking of avoiding pneumothorax with infraclavicular or more of phrenic sparing, that people can achieve in above clavicle areas also with good amount of precision and accuracy. So in present data, present scenario where we have more advancement with technology and better understanding, where is the place of a infraclavicular block where we have choices like above clavicle, axillary, or what is your take? Why we should choose infraclavicular or a costoclavicular block? At times we have to pierce two muscles, which can be painful, and in obese patients, even the anatomy is tricky.
See, there was an article in RAPM in January this year. This was the second edition of the article which dealt with diaphragm sparing blocks for shoulder surgery. Now, they presented their data And they saw that it was only the costoclavicular block which had a 0% incidence of phrenic nerve palsy. So it is definitely a useful block. And if you ask me which block would you want to do most often when targeting a brachial plexus, I would want to do an infraclavicular block. So that is my personal preference. But talking of a costoclavicular block, there is no real worry that it is deep. It is extremely superficial. And somebody had asked a question about whether we need to, I think it was Harshal, whether it makes a difference when you abduct the arm when you perform a costoclavicular block. You should abduct the arm, because when you abduct the arm, the lateral aspect of clavicle is angulated superiorly, and you can orient the probe just inferior to the clavicle. So you're sort of oriented with the costoclavicular space. And it's fairly superficial, even in obese patients. I presented that article from Brazil, in which they have clearly shown that a costoclavicular block is quite easy to perform in obese patients. So I don't think that is a problem at all.
Yeah. There was one question which was highlighted by Dr. Senthil Kumar, Praveen Kumar, and he is talking about the vascular challenges while doing an infraclavicular block. So was there any situation where you have encountered vascular anomalies or variations, multiple anatomic variations, where you thought that probably needling is really challenging, then I would like to go for a above clavicle or an axillary, and you have abandoned the block?
Absolutely. I mean, there are certain anatomical variations wherein you see aberrant arteries or you see aberrant veins, which lie in close proximity to the axillary artery. And Shomita and Sri Prakash both can testify to this quite readily. There have been instances in patients with chronic kidney disease where there's often a plethora of vessels in this particular area. And we have abandoned the infraclavicular brachial plexus block, and we have moved on to other approaches. So it is not always advisable to do in patients where there is aberrant vasculature in the vicinity of where you would want to put your needle and do your injection.
You may also mentioned about catheter placement in this area. Could you please tell
Yes.
us practical tips as what is your catheter technique, which catheters you are using, and what is your regimen when you do a block, how you do it, whether it is continuous infusion or intermittent boluses, what concentration?
Yeah, we don't get to place many catheters in our institution. That is one, especially in the COVID scenario, we've hardly had a chance to place any catheters. When we do an infraclavicular block and place a catheter, I usually tend to choose the lateral sagittal approach because the cords are deeper. And as I said during my talk, the catheter traverses through big muscles, the pectoralis major and the minor. So the security of the catheter, it's well secured because it's going through two muscles. And as I said in my video, the tip of the catheter should be just posterior to the axillary artery for ideal spread of local anesthetic. I would use a 100 mm or 50 mm needle to do a block, depending on the size of the patient. I would inject about 20 to 25 mils of local anesthetic. I create a particular space, a pocket of local anesthetic, so that when I thread my catheter, it will advance without too much resistance. And I definitely tend to tunnel my catheter at the skin. And I always put the patient on an infusion. So we generally use 0.125 bupivacaine or 0.2 ropivacaine, and we run it anywhere between 5 to 10 mils per hour. We've done it in patients where and wherein the surgeon needs to go back again and again to dress the limb or to look at the integrity of their surgery. So it is this section of patients in whom it makes a huge difference.
Is there any change of position of the catheter? Patient positioning is different while catheter placement? You recommend any?
I personally don't think so, because unless I abduct my arm, I don't have enough space between the clavicle and my probe. I need it becomes very, very difficult. There is absolutely no place if you're using a HFL 38 probe. I don't know if you use an HFL 25, it could probably give you a more space to put in your needle. But I personally would want to abduct the arm always.
There are many questions, but I'll quickly.
I think you should move on to the other speakers. And talking of baritone voice, did you hear my, can you hear me, Amit?
Yes, sir.
When I presented my video from the Ganga workshop, you
Yeah,
heard Bala in the background?
yeah.
That is baritone voice for you.
One last question, which was asked by Vrushali madam, and then with Neha, I could see. What are you using echogenic needle, and is there any role of dual modality in infraclavicular?
Of late, I have been echogenic needles, especially when you do a lateral sagittal approach or even a costoclavicular block. The visibility of the needle is much better when you use an echogenic needle. So if the patient belongs to a category where I can afford to use an echogenic needle, that would be my first choice. That is one. And two, I do not combine PNS with ultrasound. It's probably a force of habit that I tend to do it only with ultrasound, and I've really not felt the need to combine both. I mean, I only combine PNS with ultrasound when I do deeper blocks.
Fine. Thank you very much, sir. It was a really wonderful discussion. I hope all delegates must have enjoyed it. Now over to Ritesh. Ritesh will be asking questions to Hetal. Ritesh, are you there?
Yeah, I'm there. Hetal, the first question to you is from Dr. Ningaraj. Am I audible?
Yes.
Yeah.
Yes.
He has asked when you are doing a VIB, the most common response which you get is a lateral cord response. So any tips and tricks to get a posterior cord response?
Yes. So if you have seen the Gopal sir's presentation about costoclavicular approach, you must have seen that lateral cord is the most superficial cord. And posterior cord lies little bit lateral as compared to a lateral cord. So if you are getting lateral cord response, you can direct your needle bit laterally and you will find the posterior cord response. Once you get the posterior cord response, you can inject the drug and you will get a good block.
Regarding your personal choice, which PNS approach do you prefer, either the VIB or a paracoracoid approach?
I prefer to give VIB because with single injection you are blocking all three nerves, and success rate is I have seen that success rate with VIB is more as compared to pericoracoid approach. Because in pericoracoid approach, sometimes it is difficult to get all three responses. Because once you inject a drug around posterior cord, it is difficult to get the response around lateral cord or medial cord because drug is surrounded there also. And if you inject 30 ml of LA at single posterior cord, there are some chances of failure. So I prefer to give VIB, which is like postoclavicular approach with ultrasound, and it has got a better success rate with a lower volume of the drug.
Now coming to the VIB, it's your personal choice and a preferred technique. You have a lung quite nearby. So any tips to prevent pneumothorax?
Yes. I said during my presentation, so never direct your needle medially. If you direct needle medially, then there are all chances that there will be pneumothorax. If you are not getting the response, you can go either cranially, caudally, or sometimes laterally also, but never direct the needle medially. If you go medially, then there are all chances of pneumothorax, there are chances of vascular puncture, so never direct the needle medially.
How deep you are going to go? Any
Usually, yeah, usually with VIB it is 3 to 5 centimeter depth, and with pericoracoid approach, you have to go sometimes up to 6-7 centimeter to get the posterior cord response.
So basically, when you are doing a VIB, never go beyond 6 centimeter, right? If you are not getting a response
Yes,
till
yes.
6 centimeter, don't go
Then
more inside.
yes,
Otherwise, there are chances of pneumothorax. So in a paracoracoid,
yeah.
do you
If you are not getting the response,
yeah, tell me.
yeah, if you are not getting the response, relocate the landmark of relocate your entry point and then go for the response. So if you are getting proper response, then you can inject the drug. So what was your next question?
In a paracoracoid, do you prefer multi-stimulation or a single stimulation?
Yes, if you get multi-stimulation, it is desirable. Usually, if I get posterior cord stimulation and lateral cord stimulation, I don't go for medial cord stimulation, as it is lying between artery and vein. There are more chances of vascular puncture. So if I'm getting the posterior cord response and then lateral cord, I'm happy to inject drug there. I will inject 15 to 20 ml of LM at both the site, and my block will work most of the time.
Okay, thank you. Over to you, Azam, for the next set of questions.
Thanks, Ritesh bhai. Madam, Vrushali madam, are you there?
Yes.
Yes,
Very
ma'am.
much.
It was an excellent presentation. You made it look so simple. I don't think so it's that easy. Anyways, ma'am, fantastic. So,
Glad you felt so.
one question from Dr. Vijay Lakshmi. What she says is, what is your experience on RAPTIR blocks in pediatrics?
Experience in?
RAPTIR block in
The
pediatrics.
RAPTIR block, that is the retroclavicular approach.
Retroclavicular. No. I never have felt the need to do that. So I haven't given any.
Okay. And question from Anjali Chobra. Have you used continuous costoclavicular catheters in children? Or continuous
I wouldn't want to because I need the depth. Costoclavicular block is even more superficial than a classical infraclavicular block. So I would want the depth for the catheter to lie in.
Okay. And
this was a topic, Azam, which Amit gave to me to speak in Prague, which was cancelled.
yes,
I
sir.
protested to Sandeep. I said, I have no real experience with this. But if you see, the costoclavicular space communicates superiorly with the supraclavicular fossa and inferiorly with the rest of the medial infraclavicular fossa. So what is the fate of the tip of the catheter? We don't know. It may go up, it may go down, it may not actually lie in the costoclavicular space itself. So I think somebody needs to do some cadaveric studies with dye injections to know exactly.
Yes, sir. Thank you, sir.
While actually TVS was mentioning this, a thought came in my mind which I would openly want to speak out. Probably this is why in our dye studies, which were classical infraclavicular, we did not find anything going up in the neck. But when some other authors have done it, they did see it going there up in the neck. So maybe they were more in the costoclavicular area than a classical infraclavicular one.
Yes, ma'am. So the other question was from Ruth. How much the local anesthetic dose for pediatric patients?
Ruth, I'm very glad you asked this question because this is where the entire crux is. I would just give an answer in one line. For any peripheral block, use 0.2% ropivacaine in 0.5 ml per kilogram. So if it is a 10 kilogram child, you give 5 ml of 0.2% ropivacaine or 0.25% of bupivacaine. That's all. Don't confuse yourself any further.
Yes,
It can be less, but don't make it more.
Yes, ma'am. So I think Dr. Uma from Davangere, she's my colleague, she also had the similar question of giving continuous costoclavicular block in children. So we have answered that. Sir, I think questions to all the three speakers. Have you noticed an increase in regional anesthesia utilization during this pandemic? Have you noticed an increase in regional anesthesia utilization during this pandemic?
Yes, I would say yes, because
Yes.
we try our best to avoid general anesthesia. See, as such, we are looking for reasons to avoid general anesthesia, being regional anesthesia enthusiasts. And now this COVID pandemic has given us an additional reason to avoid general anesthesia. We can talk about aerosol and the spread, and the surgeon says, you know, they immediately say, "Jo karna hai kar le," make sure the patient doesn't complain. So, in fact, today I did one 77-year-old lady. I gave a spinal for a bipolar hemiarthroplasty of the hip, and I gave her a supraclavicular brachial plexus block for a radius fracture. So I think we will always try to do as many blocks as possible in this given time.
True, sir.
Asim, I have some other take on this. I'll tell you my personal experience, what's happening. For us in children, anyways, there has to be a sedation or GA and then a block. So in pediatric practice, it hasn't changed a bit, but we keep on, we continue what we are doing, but my adult practice has increased.
Correct, ma'am.
Yeah.
Thank you.
There are 2-3 questions for TVS Gopal sir as well. So Dr. Abhijit Nair is asking, which is spinal anesthetic of upper limb? Is it supraclavicular or infraclavicular? What do you say?
I answered to him offline, but since you asked, I'll tell you. I think if you have to say what is the spinal of the arm, it has to be supraclavicular.
Okay.
Because there is going to be a bit of spread towards the interscalene region as well. And if you inject a large volume, maybe the cervical plexus also. So that would be the spinal of the arm, and definitely not infraclavicular brachial plexus.
And Dr. Anjali Chabra is asking you one question that the block works well intraoperatively, but postoperative congruent segments are not blocked. Do you reposition your catheter and how?
I don't do too many catheters. I must be very frank about that. But the few that I've performed, I really have not come across a problem where my surgeon complained when they took the patient back to the theaters again and again. So I probably am placing them right, or maybe securing them right. Maybe they are not moving once they are placed.
Yeah. There is question.
May I just add a bit for this? Anjali, try giving a bolus through that catheter, a very acceptable bolus through that catheter. That probably might increase the drug spread and probably might take up those nerves which are not bathed by a continuous one.
So you're saying intermittent boluses?
Just try when it is not so. Otherwise, it's not required.
Only when there is missed segments.
Yes.
Okay.
Then Dr. Ritesh is asking, and also Dr. Vrushali Ponde, they are talking about in plane, out of plane, and Dr. Ritesh has asked, how can we have a needle? At times it happens that when we pass the needle, it is not seen at times. We struggle, So what are the tips and tricks so that all throughout the block, the needle, the shaft of the needle and the tip is seen nicely if we are doing in plane? Or you recommend out of plane? What is your opinion on that?
I had Siva do the costoclavicular brachial plexus at my workshop this January, and he performed it by doing out of plane. And he finds that approach very, very comfortable. So how out of plane works, if Siva is still on, yes, he is there. You can unmute him and ask him to give his inputs on that. But when you do it in plane, going from lateral to medial, I had this problem. The first maybe 10, 15 blocks which I did, I was not able to pick up the needle. I think it's just a bit of orientation, how you angle the probe and how you orient your needle along the beam. So what I do is I introduce the needle by just say 2 or 3 centimeters. I don't go beyond that. And then I orient my probe to be able to pick up the needle. And once I pick up the needle, then while holding the probe steady, I advance the needle further. I think that would be the best trick to keep the needle in view at all times when you do any block. I mean, leave alone the costoclavicular block.
One
Shiva
last.
is here, so he can talk about out of plane approach.
That is perfectly right. I mean, it is basically the skill. And as you said, the costoclavicular space is a little inclined. The probe is little, because you have to insinuate under the clavicle to get the subclavius into the picture. And it is basically a skill. And as you said, once you get the needle visibility, you are holding the probe tight and move the needle in plane is the trick that you have to do it. Out of plane, we choose because the ergonomics we practice in that way. We stand the lower side of the hand, and getting the needle visibility in the out of plane is another little more advanced trick that you have to gain after practicing with an in plane enough. In that, there are two approaches are there. One is a dynamic needle tip tracking. In that way, because it's very difficult to demonstrate here, where your needle goes, and then once you see the needle just above the target, you have to tilt the probe along while the needle is advancing. So it is as the needle moves, your ultrasound beam also moves. So for that, you have to scan the target before for about 25 to 30 degree tilt. You are keeping the target visibility. Then you have to choose that place, and then you have to, with a shallow angle, first you go on top of the target and then move as the needle advances. So all these things you have to pre-calculate before. If this sort of a scanning for about 20 to 35 degree, if you're not able to visualize the target, then you should not take that for out of plane approach. So these are all the bit of tricks. So in either approach is fine if you can able to see the needle tip, and the needle tip visibility is purely a skill that has to be acquired by practice. There is no shortcut.
Shiva sir, we have question. Now you are into research with above clavicle blocks where upper truncal, middle trunk, inferior trunk, everything has been nicely defined. And we are talking of costoclavicular block today. So what you think is the place of costoclavicular block in present era? What are the indications where you would like to consider this block? And also, please tell us your thought process for pre-injection, what that has been mentioned.
Yeah, I would say, I don't want to discriminate, any block which is superior or inferior. Everything has got its role. Above the clavicle, the brachial plexus elements are little spread over a wider area, whereas the connective tissues are loose. Whereas when you come to the costoclavicular space, all the components are organized into 3 compartments, and the relationships are well established and they are consistent. This is the only 2 predominant differences. And as already Gopal sir said, if you go to the costoclavicular space, it well communicates to the supraclavicular space. So the biggest difference what we perceived is in the incidence of phrenic nerve palsy. This is with 20 ml injection. If you do a supraclavicular, that is only hardly a centimeter above the costoclavicular space. The incidence is up to 45 to 50%. Whereas 1 centimeter below, the same 20 ml in a single point, the same injection technique, the performer is only 2 people. The incidence is 5%. So whenever you are worried about a phrenic nerve involvement, choose a costoclavicular. So this is, we can confidently say with an evidence what is accumulating now. So this is the advantage I can claim for costoclavicular. When you go to the supraclavicular, the incidence of phrenic nerve involvement is much higher. So this is what I can talk about costoclavicular. And then secondly, about the abduction and adduction. So as the question arises whether we should abduct. So now what happens while we are abducting is the clavicle moves away from the axillary artery by 2 centimeters. Since it moves out, it allows us to scan the brachial plexus 2 centimeter proximal. So these two things are consistently happening. When you adduct the hand, the clavicle shrugs over the rib cage. You may not able to scan the brachial plexus more medially. When you abduct, it elevates for about 2 to 2.5 centimeter, and it allows us to scan the brachial plexus, axillary artery, axillary vein about 2 centimeter more proximally. So your ability to pick up the costoclavicular space is more correct when you abduct the hand and then scan. If you adduct, you will be, when the cephalic vein will be opening, you may be in the lateral infraclavicular fossa, that is below the pectoralis minor. You may not be exactly in the costoclavicular space. So abduction of the hand is critical and crucial to identify the costoclavicular space, which moves the clavicle by 2 centimeter cephalad and allow us to scan the brachial plexus more proximally by about 2 to 2.5 centimeter. The big difference.
Yeah. Lastly, your comment on pre-injection.
Yeah, see, sometimes whenever you do a costoclavicular, the target can be deeper. You may not delineate so clearly. It is always with clinical situations. You desperately wanted to do the costoclavicular, but your targets are not so clear because of various reasons, echogenicity, depth, and so many factors. You are desperate to do that. So what you can do it, you can go to the supraclavicular fossa and inject a few ml of local anesthetic, say 3 to 4 ml, because these two spaces are close to each other. When you come back to the costoclavicular space, because of this local anesthetic coming to the elements of the brachial plexus, you can see the targets more clear. These are all simple tricks where you wanted to see the costoclavicular, but it is quite deep and the echogenicity is not so good. This is one way to overcome it. Because since you have an ultrasound, you can just place it above and see the cards are good. You put few ml of local anesthetic. You're worried if I inject 20 to 25 ml there, my phrenic nerve involvement is more. You just inject bit of local anesthetic so that when you come back, this local anesthetic create a contrast between the neural elements and the hypoechoic local anesthetic. Now you can see the elements better and you can perform the costoclavicular. That's a simple trick to overcome poor echogenic window at the costoclavicular space.
Yeah, thank you very much. Thank you very much for that elaborate description.
For,
Question
TVS
to all faculty members: role of adjuvant. So we want to hear comments from all faculties. What is the role of adjuvant in this block? Are you practicing, or what is your recommendation? TVS.
My personal preference is not to use adjuvants.
Okay.
I'll out for that.
I stay away from adjuvants, so I leave it to the others to talk.
Yes.
So my take on this is, there is so much variation in my technique itself. See, when we look at the technique so critically, a little bit of going inside, the volume concentration, this itself changes the dynamics of a block a lot. So if you use a consistent injection technique with a fixed local anesthetic volume and concentration, you can produce a predictable blockade. When you have a predictable blockade for about 5 to 10 hours, and there is not much of need to add another one drug to in a routine clinical practice. Maybe you can talk about very high intense extensive tissue loss where repeated dressing, that's a different ball game altogether. In otherwise settings, I personally don't find a need to add an adjuvant if you have a consistent block, and it can be easily managed with oral analgesics. I wanted to have my blocks more predictable, like spinal and epidural.
आजम हेतल को अनम्यूट कर, हेतल को अनम्यूट करो आजम.
हाँ.
Yes, Vrushali madam, any role?
Yes,
Yeah.
I in my practice there is definitely a role for adjuvants. I categorize post-operative pain into three, in fact. One is something that is not too much and can be easily handled with oral analgesics. Second one is something that is not as little as the first one, but is not as bad that a person is going to hit the roof if orals, even with orals. So that's in between. And the last one is do what you can, but only a regional would relieve the pain. So if the surgery is the back shoulder repair, I would put it in a catheter. If the surgery is somewhere in between, I would put clonidine. In children especially, we would go very safely to clonidine today. in a dose of 1 microgram per kilogram, and nothing more than that. I don't think I've used any other adjuvant for a long time, for many years now, other than clonidine. In adults, for especially for shoulders, I go to dexamethasone, because I always feel that there is some chronic pain component there, and there is no scientific evidence to what I'm speaking. But I feel, I mean, what I have observed is the analgesia time definitely has prolonged with this additive.
Hetal?
And for smaller surgeries, additive, but I would go for an additive. Yes.
Yes, Hetal, you want to add anything?
Yeah, I never use any additive, but I used IV Dexona in all my patients, and some study says that IV Dexona, if you give IV Dexona, it can also prolong the effect also. So I use IV Dexona in all my patients.
Yeah. Now, one more question to all faculty members. Have you seen any complication with these blocks in your? If it is so, what
be ready to deal with. The second complication, which you could definitely look at, is some sort of a neuropathy, especially with infraclavicular blocks, where lateral cord is quite often very well seen. Posterior cord, you really don't know many times, and the medial cord also, it's not easy to pick up. And there's some evidence with a RAPTIR, I told you that. There are instances where in cadaveric studies, the needle has been placed within the nerve. So neuropathy is something that we need to be keeping in mind and be able to deal with. But thankfully, most of the time it is neuropraxia and nothing more serious. The third complication which we would potentially encounter, and I have encountered once, is local anesthetic systemic toxicity, because you are injecting in the vicinity of two great vessels and they have multiple small branches. In fact, I think Dr. Senthil was asking me if in one of my slides I showed a small round spot medial to the axillary artery and asked, is this the thoracoacromial artery? It could be. So
Of block for more than almost 40 hours. In at least one case that I remember, and she called me back saying that this is what is happening, and I almost thought that it was an injury. We really don't know where the posterior cord is, or maybe we don't know whether we are injecting in the posterior cord, perhaps. And those were our initial days when we had just started. So that was one incident I remember. I also remember she coming back to me saying that 2 or 3 of the fingers were very, very long time. And so that is one memory I have. Touchwood, I haven't seen a last as such with infraclavicular block yet. Neither have I seen a pneumothorax.
okay? Hetal,
Yeah.
you want to add anything or?
Yes, I have never seen any complication with infraclavicular, but one of my junior gave a interscalene block in a diabetic child. He was 14-year-old patient, uncontrolled diabetes, sugar was remaining almost 400 plus, HbA1c was 10 plus. He gave interscalene block. Unfortunately, I was in another OT and he gave with hypodermic needle. And patient had no movement in hand till 48 hours or so. We were very anxious. Luckily, movement came, but there was some restricted movement, as Vrushali madam said. In our case, it was in elbow. But but after a few weeks it recovered completely, so we were fine. But when we did the nerve conduction study, we found that patient had peripheral neuropathy, and he had peripheral neuropathy in both upper limbs. So that was because of diabetes, and we added block, and patient had a neurological complication. Luckily, I have never seen last in my practice.
Okay, thank you very much.
There
Yeah.
is a question from Sandeep Mutta. I think I'll ask Hetal and Vrushali to answer this. Can we give a brachial plexus block in a patient with trigeminal herpes?
Trigeminal herpes in which area? In which
Trigeminal
area
herpes, so it would be
which
along the
area it is
distribution of the
exactly
trigeminal
taken
nerve.
up?
So I think it would not be a good idea to mess with peripheral nerves in a patient who's got herpes. My take on it would be keep away from doing any. In fact, if you remember, they say don't even do elective surgeries in patients with herpes because it can flare. So if you can have such an inflammation, expect something like this.
Yes, regarding
what
that, and there is an herpes reactivation when they come in the specific dermatome at the thoracic level. We did paravertebral block to relieve that. That is a reactivation at a later stage when they come for shingles, which is reactivated, and they have severe pain at that. It was a good relapse for a month together, but not in an acute episode. These are all chronic pain settings. So that is where we did things.
I have heard of, and I have known some patients who have felt better with prilocaine applications, even in the acute infection. So if that helps. But no, I haven't, I've never heard of a nerve block being given.
Yeah.
So Amit, I have a question to TVS sir.
Yeah.
One last question.
Okay.
TVS sir, like we are using an infraclavicular block for anesthesia.
Yeah, I would place the tip of my catheter, as I said earlier, between the axillary artery and the posterior cord. And when I usually keep it around 8 mils per hour. So that is a fairly constant mass going in. So I think that mass would be enough to soak all the 3 cords.
Thank you, sir.
And as well,
so can we end here? I still need to go home. I'm in the hospital.
Okay, thank you very much. I think questions can still continue like that. Before I forget, and you all must have received so many mails from Sono's side. I wish to express gratitude on behalf of Aora to Ms. Kavita. She took a lot of effort, so many mails to, and that is why 375 delegates were there today. And really grateful to my team members as well, to whole executive committee of Aora, which help us in propagating this message of this conference, this webinar. So thank you indeed. And we really had a wonderful question answer session. Thank you all faculty members. Thank you Ritesh, and thank you Azam.
Ritesh, would you be giving us certificate?
Yeah. The certificate will be yeah, it will be mailed, or we will send a link so that they can download the certificates. And
yeah, his internet is unstable. Okay, thank you very much. So we'll close this meeting now. Thank you.
Okay.
Thank you all. Thanks.
Bye.
Shiva.
Thank you.
Thank you.